Transradial access is much more comfortable for the subject as it does not compromise the mobility in the immediate post-procedure period, unlike transfemoral procedures. Moreover, access site bleeding problems are much lower compared to femoral arterial access. But the downside of transradial procedures is the sharper learning curve and the slightly higher radiation exposure for the operator. Another problem is spasm of the radial artery, which can limit the number of catheter exchanges and sometimes necessitate changeover to the femoral route. Radial route does not need prolonged manual compression for hemostasis. Arterial access sheaths can be removed soon after the procedure, even on anticoagulation in case of percutaneous interventions. There is a small rate of late loss of patency of the radial artery after transradial interventions, though these seldom produce clinical ischemia. Allen's test for documenting the adequacy of the palmar arch would be a prerequisite prior to transradial access, keeping this aspect in mind, though some have challenged the utility and need. The procedure is initiated by localizing a good radial artery pulsation a few centimeters above the wrist. A small skin fold is lifted and local anesthetic instilled subcutaneously. A small nick is made with a scalpel, again after manually lifting a skin fold to avoid nicking the radial artery. Then an intravenous cannula is slowly and steadily introduced into the radial artery, trying to avoid a counterpuncture. Once the backflow of blood is noted at the proximal end of the cannula, the tip may be introduced minimally forward to secure the vessel access and the stylet withdrawn, leaving the cannula in the artery. Then a hydrophilic guide wire is threaded through the cannula, making sure that it is done only when a good retrograde jet of blood is visible. The wire should pass smoothly into the artery without any resistance. If necessary, the wire track can be visualized on fluoroscopy. Once the wire is securely within the radial artery, the cannula is removed over the wire and the radial sheath, usually 5F, threaded over the guide wire and the guide wire removed. The side arm of the wall sheath is open to ensure a good backbleed before injecting the cocktail of dilute diltiazem and nitroglycerin, or sometimes nitroglycerin alone, to prevent spasm of the radial artery. Heparin is given either intra-arterially or intravenously at this point. Once the sheath is ready, a guide wire is gradually introduced into the sheath using an introducer and passed up the radial artery into the brachial artery and subclavian arteries under fluoroscopic guidance. Difficulty may be experienced in negotiating a tortuous subclavian artery, especially in older individuals. Pushing the guide wire during a deep inspiration will often help it fall into the ascending aorta rather than into the descending aorta. The diagnostic catheter is also usually introduced along with the guide wire, keeping the tip of the guide wire well beyond that of the catheter. A tiger catheter can be used for angiography of both the coronary arteries, or specific Judkins catheters can be used for each coronary artery. The tiger catheter usually reaches the non-coronary sinus during initial introduction or may even jut into the left ventricle. It is gradually withdrawn so that it falls into the left sinus and on still withdrawing into the left coronary ostium. Slight clockwise torque may be required for proper seating of the catheter within the ostium coaxially. After obtaining the left-sided injections, it is decannulated from the left coronary ostium and pushed down the aorta before withdrawing and turning it rightward to engage the right coronary ostium. If the coronary anatomy is one which requires coronary artery bypass grafting, the left subclavian artery is cannulated in the return track of the catheter by pushing it leftward when it reaches the arch of the aorta. A guide wire may have to be used to maneuver it into the left subclavian ostium. A left subclavian injection is usually sufficient to adequately opacify the left internal mammary artery. Compression of the ipsilateral arm during injections give better opacification by avoiding flow into the arm and directing more flow into the lemma. After transradial angiography, if it is decided to do a transradial coronary intervention, the 5F sheath may be exchanged for a 6F sheath. This is done by initially reintroducing the hydrophilic guide wire, removing the 5F sheath over it, and then threading the 6F sheath over the guide wire, applying compression on the artery to avoid undue bleeding during the sheath exchange.